Good morning, all. We're going to be starting in about 3 minutes. We'll be starting in about a minute. Good morning, everybody. Good morning, everybody. Welcome. We're going to go ahead and get started. I hope everybody is having a wonderful start to the second day of the Center of Excellence Infant and Early Childhood Mental Health Consultation Conference, Equity from the Start. My name is Sarah Javidon, and I am with the Center of Excellence, Georgetown University Center for Child and Human Development, and I will be serving as your facilitator today. I'm joined by Monica Ruiz, who is our tech host, and will be able to help if anybody is having any technology needs that need attention. Feel free to drop a note into the chat. We are pleased to be hosting you all today. I see we've still got a few people joining, but we're going to go ahead and get started. As we've got 50-minute sessions, as you all may know, and we've got a lot of content from our wonderful Colorado team to cover today. So this session is being recorded, and transcription is going to be available through the Zoom platform. If you have any questions, please feel free to type in or relay your questions into the chat, and we'll be monitoring that chat throughout the presentation. So if you have any technology questions, if you have questions for the presenters, or if you have questions generally about the conference or session slides, things like that, feel free to type them into the chat and we'll be monitoring that. We also want to let you know that before we begin, that all the views and policies and opinions that are expressed in this presentation are those of the session content authors and don't necessarily reflect those of the Substance Abuse and Mental Health Services Administration or Health and Human Services. So that said, I would like to introduce our presenters today from Colorado. We have Dr. Ashley Sward, sorry, I got that wrong. We have Christine O'Brien, and we've got Lisa Schluter. And they're going to be going through the workshop today titled Meeting Colorado Families and Early Childhood Professionals Where They Are, Mental Health Consultation Across Settings. So we will have time at the end. Our Colorado team is going to provide some time at the end for questions and answers. So please feel free to type your questions into the chat and we will address those at the end. But if you have any questions that need like clarifying or technology questions that need immediate attention, feel free to type them in and we'll respond to those. So on that note, I'm going to pass it on to Lisa Schluter from the Colorado Department of Early Childhood. Welcome.
Thank you so much, Sarah. We are super excited to be here. I hope everybody is enjoying day 2 of the conference, Equity from the Start. We were here last year talking a little bit about our consultation program at the state. I sit at the Colorado Department of Early Childhood, and I'm super thrilled to be joined by colleagues today to share a little more about other efforts that are happening in Colorado to meet children and families where they are. And so really briefly, again, our presenters as well as our organizations, I will let them tell you everything there is to know. The abbreviated version, just the good stuff, in just a moment here. So Ashley and Christine are my counterparts this afternoon. And as I mentioned, we have been here. We had the honor of being here last year to talk about the state-administered consultation program. So I'm going to tell you a little bit about that just as a refresher around Colorado's really rich history in this space, and then again, introduce you to 2 innovative programs that have been taking place over the last couple of years that we're super excited about. So our consultation program is no cost, it's adult focused. We offer 3 levels of service. So we have child, classroom, and program focused services in the state of Colorado. And our workforce typically has a master's level mental health degree that's license eligible. We have 21 teams that represent about 52 FTE, and they cover all 64 counties in Colorado. I mentioned we were here last year giving a presentation. I was joined by my team, Allison Hargarten, and we did a presentation on developing Colorado's model of consultation. So as I mentioned, we've been around for a long time doing this work, and in 2020 and then 2021, we had some important legislation passed that essentially required us to really formalize and standardize Colorado's delivery of consultation to ensure that those children and families, as well as early childhood professionals in the Northwest, are received similar services, high quality, access, equity as those in the Southwest or Southeast. This has been a big focus of our team for the last couple of years, and we are headed into evaluation. So we look forward to coming back and sharing what we find when we finish our evaluation project. And so big picture, I mentioned Colorado has a robust history here. We have over almost 30 years of infant and early childhood mental health efforts in the state of Colorado. They're pretty broad, and I think those in our state as well as those in other states often hear about the state-administered consultation program. But like I said, we're doing so much more in Colorado, and this is just a sampling of some of those other great efforts. So I have a brief timeline here, and we'll be sure to drop that in the chat, but essentially these are some bigger milestones after 10 years. So we piloted our ECMH program in 1998. We had a systems building collaborative. We produced a report for risk, reach, and resources, really trying to understand who would benefit most, how do we get services there, and what does that look like? And I'm really excited to see what the next 10 years bring. So without further ado, I'm going to hand it over to Christine to tell us a little bit about home visiting.
Hi, my name is Christine O'Brien, and I work at for Parent Possible, which is a nonprofit in Denver, Colorado. We are the state oversight agency for parents as teachers and hippie home visiting programs. So I'm here today to talk about our enhanced home visiting project, which centers on mental health and wellness for the home visitors. And moving forward, I'll be referring to the project as EHV. Next slide. So the project aims to improve social emotional well-being and behavioral health for home visitors and supervisors. So through EHV, the home visitors and the supervisors are offered regular reflective consultation, training, and mindfulness support to equip them to better serve their local communities. So this program was really born out of the recognition that home visitors are not equipped to address complex mental health needs of families. And they need their own support around their own wellness and secondary traumatic stress. So this project was launched in 2017 with a 3-year grant. It started with 7 sites in Denver. And this project was, some of this work was already being done, and so it was inspired by Project Launch and Launch Together. We are currently now serving 29 programs, around 150 home visitors, 32 supervisors, and we have over 18 mental health consultants that are providing the services. And we have been fortunate enough to receive funding through 2 Colorado-based foundations who really value and support the project. And then also certainly the state of Colorado is committed to funding this project using MICV funding. So this lists a lot of goals, and I'm not going to read them all to you, but throughout the years, we've had many different goals around the project. And really the main goal is to improve the self-efficacy of the early childhood workforce, specifically home visitors. And then ultimately, this improves outcomes for the families that they're working with. So, can you skip this slide and go to the next one? Thank you. There are 3 main components to the project. The first is having a reflective consultation group-based sessions for home visitors. So we contract with mental health consultants to provide this service. The group meets monthly for like 60 minutes. There are options for one-on-one sessions when needed. The groups, some are in person, but most are virtual. And the site, the program, gets to choose the mental health consultant who must be licensed or hold an endorsement. So we have a group for the home visitors. So we also have a reflective consultation group for the supervisors. And these are the people who are supervising the home visitors. So this group really focuses on helping supervisors support their staff and to increase their own self-awareness and reflective practice with home visitors. So this group also meets monthly, usually 90 minutes, and they also have options for one-on-one sessions. And the final piece is wellness consultation and training. So then they all come together, the home visitors and the supervisors, and they get a quarterly wellness consult. So the entire team is together. And this really focuses on wellness and mindfulness. And this group is conducted by a bilingual licensed mental health consultant. So we do conduct a one-time trauma responsive survey for any new sites joining the project. And really, this is just helping us determine sort of a starting point of where this site or organization is. So we ask questions around staff training on trauma, cultural responsiveness, staff support on self-care. And these results are then given to the mental health consultant who provides those wellness consults. She reviews the results with the whole staff, and that sort of gives a baseline starting place for her work. So now moving into evaluation. This is a general slide of what our evaluation process looks like. And really what I want you to know, the key thing to know, is that we focus on sites, supervisors, and home visitors, not families. So the families and the children are the end result, but this project is really built around the people who are providing those services. You can go, okay. And so we use lots of tools. We do a post-retrospective survey. There are questions in that from the ProQual, which looks at compassion satisfaction and compassion fatigue. We have questions from the CAMS-R, which looks at mindfulness, and we conduct focus groups, and then we also do training evaluations. So this is, we do this every year in the spring. So we just did it in April in 2023. We had 92 participants respond to the survey. So just to highlight some of the demographics from this is that our largest demographic is Hispanic and Latino. Our highest percent in age is 20 to 34 years old. So most of our home visitors, it's a young workforce. And we also ask them how many hours a week they work. And unfortunately, 25% of the staff reported that they work over 40 hours a week. So just some results from this latest evaluation. Most home visitors rated the EHV project is very helpful in improving their effectiveness in working with families and also helping them support families. For self-awareness and reflective capacity, the participants reported stronger self-awareness and reflective capacity. And then we talk about being able to navigate job stress, and 81% reported stronger ability to navigate their job stress as a result of the project. For the compassion satisfaction, 57% reported higher levels of compassion satisfaction, but you can also see that lighter orange, which is 23%, had already reported the highest possible score. So we feel that that project is helping with compassion satisfaction. And finally, 82% of our participants reported higher levels of mindfulness after participating in EHV. So this was done through a survey. We also collect a lot of qualitative data that we get from focus groups and interviews that support all of these numbers. So overall, our key findings over the past 6 years, we've found that EHV continues to be received extremely well by the home visitors and supervisors, and the participants really value that participation. And a few of the challenges that we do have with the project is there can be a lot of staff turnover among sites. With home visitors, it's kind of like the same in early childhood education. Finding teachers, keeping teachers, the same happens with home visitors. So when we have turnover, that disrupts the groups because, you know, they've built this relationship and now there's turnover. We have some issues finding bilingual mental health consultants because we're finding we need more bilingual people. Time for check-ins with the sites and the mental health consultants, and that's just kind of a capacity issue. We've grown so much in the past 6 years. And then mental health consultant support and training. We have a huge variety of mental health consultants, people who have just come into the field, and then people who have been doing it for over 30 years. So trying to figure out among this group what kind of support they want and what kind of training has been a little challenging. And then, of course, funding for the mental health consultants. So just some quick lessons that we've learned. that trust is really important between these mental health consultants and these home visitors, that these groups, need to build that for it to work. That quantitative data doesn't tell us the full story, so we really focus on gathering qualitative data. Also, the importance of agency support. A lot of these agencies, PAT and HIPPY is a very small part of their organization, so having that organization really support this work. And then also the supervisors supporting the home visitors in this. We had some challenges in the beginning in the rural areas of Colorado where there might be one home visitor, one supervisor, and finding a mental health consultant, but we found that virtual consultation is a great option. For those smaller rural areas, we do combine them now so that they can be a bigger group, usually around 5 or 6 people. And then just being flexible, because we are serving the whole state, which is very large and diverse. So just making sure that we're meeting the needs of each one of these sites throughout the state. That's just my glossary. So if you have questions about what those are. So thank you.
Excellent. Thank you so much, Christine. It was fun for me to kind of learn about your program and see some of the similarities. So I'm sure you all will pick up, as I did, some of the same opportunities and struggles that embedding this service in various sites can bring up. So my name is Ashley Sward. I am a psychologist. I am with the University of Colorado School of Medicine, and I'm also the Associate Director of the Warm Connections program. So Warm Connections is an integrated behavioral health and developmental support service for families and staff in WIC clinics. So the Supplemental Nutrition Program for Women, Infant, and Children in the Denver and Arapahoe counties of Colorado. In 2015, a task force made up of university personnel, several metro community mental health centers, as well as Denver and Tri-County public health entities met to discuss opportunities for serving the infant and early childhood population in Colorado. And what was born out of that was Warm Connections. The mission of Warm Connections is to mitigate the impact of psychosocial stressors and improve access to the early childhood mental health system of care for low-income, at-risk women, infant, and children, while also simultaneously increasing the infant and early childhood mental health workforce. So, with those goals in mind, this task force, through trial and error, really ended up landing on the WIC program. So I want to share a little bit about why that was. So one of the very first reasons is because of the demographics of WIC participants. So as you can see here, eligibility for services is for women who are pregnant and then children up to the age of 5. So this was the exact population that this task force was looking to serve. So we really did find that this was a wonderful overlap. Second, WIC is uniquely situated for eligibility that gave us really increased access to the individuals that we wanted to serve. So eligibility guidelines mean family with incomes at 185% or lower of the federal poverty guidelines are eligible for WIC. And that is more inclusive than many of the other benefit programs in our state. So it was this wonderful combination of a wider reach for individuals, but still within that lower socioeconomic status demographic that we were really hoping to help serve. The other piece of this that's really important is that we learned that WIC serves 53% of all infants born in the United States. So again, this wide catchment of young children and families. So as you can see here, some of the families in WIC do participate in other federal government programs. So there is some overlap between SNAP, which is the food stamp benefit in Colorado. There is significant overlap with Medicaid, given that Medicaid participation meets automatic eligibility requirements for WIC. So any family that comes in, if the parent or the child is enrolled in Medicaid, they automatically qualify for WIC services. And then a little bit of overlap again with the Temporary Assistance for Needy Families program run through DHS in our state. So what we appreciated again about this is that WIC has a wider catchment and it's still a benefit service. And so we recognize that families were already accessing support through this program. They were already in a help-seeking mode. And we came to learn very quickly once we got in and integrated with WIC that the WIC staff themselves do an amazing job connecting with families and building trust. So we were able to kind of support that and further that by becoming a part of the WIC team. And families were more likely to kind of trust and engage with us and feel less stigmatized doing so because of the support we received from the WIC staff in connecting families with us. So this is just a snapshot of the program participant demographics between the Arapahoe WIC clinics and the Denver WIC clinics, which are counties in Colorado that we have warm connections embedded into. So as you can see, we serve a diverse population. So the majority of the participants in these 7 clinics are Hispanic, and then also a lot of individuals that identify as Black, African American, and then we have white, as well as Asian, and then multiple racial ethnic identities. So to serve such a wide, diverse population, you will see here in a minute that both the WIC staff as well as the Warm Connections specialist staff are mostly monolingual speaking and white identifying. And so what we have done to kind of support increasing our understanding and connection with individuals from diverse groups is we really rely on the diversity informed tenants for work with infants, children, and families. So all of our specialists get kind of ongoing reflective supervision in that model and support. And we also work really closely with affinity groups that we connect with. So we have a program called Black Mama's Circle that's a perinatal support for Black women in the area, as well as the ALMA project, which really focuses on supporting Latinx individuals. Lots of different languages spoken by WIC participants. We are able to use an interpreter service. So all of the WIC clinics that we're in use interpretation services, and we have the luxury of also being able to utilize that support so that we can connect with families who speak just about any language. We have yet to find a language that we haven't been able to support. So we support, differently than Christine's, our program really started out as wanting to connect with families, wanting to connect families to early intervention, the early childhood system of care. And as we got into the program with that focus, we really started to realize that it was the WIC staff that needed a lot of support. So I think Christine mentioned that they observed that some of the staff were really not equipped to handle the complex needs of these families through no fault of their own. They just weren't trained on it. And that is really what we observed when we got in and started working with the WIC staff. So there's a wide range of education levels, GED, high school graduates, all the way up to master's level registered dietitians. And so there was a wide range of experience as well as training. Also a wide range of tenure. There is also quite a bit of turnover for WIC staff. It's a challenging job, but there are also those that have been there in these clinics upwards of 20 years and serving generations of families. And then in order to accommodate the language diversity, approximately, and this fluctuates, a quarter to half of the staff are identified as bilingual, Spanish speaking, and then there are a few other languages as well. So just to recap, why WIC? We recognize that WIC provides service to so many infants in the US and some of the most at-risk families. We also saw that families were seeking help from WIC and had regular visits. So they were engaging with the program every 3 months. We also, in looking at the literature, recognized and found that rates of mental health concerns, specifically perinatal mood and anxiety disorders, are actually higher among WIC participants and WIC eligible participants. We noticed a lack of just-in-time preventive services in our area and wanted to fill that need. And again, once we got in there, we really recognized that WIC educators didn't have the time, training, or resources to address the complex needs that families were presenting with. So Warm Connections staffs 7 clinics with Warm Connections specialists who are all infant mental health and early childhood mental health trained. So most of them are endorsed. We do also train a postdoctoral fellow through the Harris Program of Infant Mental Health and Early Child Development at CU. And they rotate through our program every year and are placed at a clinic. All of our Warm Connections specialists receive training in the FAN model through the Fussy Baby Institute or Erickson Institute. They also receive Healthy Steps training, which is developmentally focused for young children and families. And then, as I mentioned, the Diversity Informed Tenets training for work with infants, children, and families. Each Warm Connections specialist receives ongoing individual and group reflective support from myself, as well as the executive director of the program. And as I mentioned earlier too, we are unfortunately all monolingual, but we do use interpretation services, and we are always looking for individuals who are bilingual. The goals of Warm Connections is really to, on the family side of things, increase caregiver confidence and competence. So that really is that kind of FAN model from Fussy Baby. We also wanted to make sure that the caregivers felt heard and supported. We also wanted to make sure that staff at WIC also felt confident and competent in meeting the needs of the participants of WIC, and opening up access to the early childhood system of care was important. And through this, we also hope to decrease caregiver stress, caregiver feelings of isolation, unsuccessful referrals to community resources. So we know that there can be huge challenges in giving someone a referral or recommendation and not having individuals follow through or slipping through the cracks. So that was really important to us. And then we also wanted to make sure that we were decreasing job stress for WIC staff and educators. Support for the families can look a lot of different ways. It can be talking through concerns about child's mood, behavior, development, And really what we want them to leave with is a plan for feeling confident and competent to address that concern. We also are available to talk through parents' concerns about their own mood or behavior. We have done a lot of perinatal mood and anxiety disorder screening in clinics. That was actually born out of the request from the staff saying, hey, we know that this is happening, but we're not quite sure how to assess and address it. And so we worked with them to create a model for doing so. And then we really work to connect families to resources and provide in-the-moment support to access those resources. I will pause and say that WIC in Colorado, all services at the start of March 2020, because of the pandemic, shifted to telephonic support. And that actually did not end until last month in the entire state of Colorado. So all WIC services went from being delivered mostly in clinic and in person to all over the telephone. And so that was, as we'll talk a little bit about, a big challenge for us to meet and kind of pivot to support both families as well as educators in making that transition. But it also really increased the need of families for social determinants of health. So a lot of what we saw increase was families who just needed basic needs. So our support for the WIC educators and WIC staff really is flexible. We have an open door policy that anytime an educator needs to talk through a challenge or a worry, they can set up a time to meet with us. And we are really well supported by clinic leadership in offering that time to the WIC staff. We also do a lot of trainings on topics related to social emotional health, child development, child behavior, caregiver mood, etc. And that can be anything from doing an all staff training where we do a formalized training, let's say on typical development at a certain age, or it may just be meeting with certain clinic staff to talk about maybe something that they're seeing in their work that is clinic specific. And then we also link educators to additional resources in the community if they desire that. We have a great working relationship with the mental health and behavioral health and physical health programs that all the staff are engaged in through their both employee assistance as well as their insurance. So briefly, Warm Connections pilot outcomes. So really what I want to highlight here is that we did do a needs assessment to see what WIC staff wanted and as well as WIC families. And what we found from that was WIC families were really interested in assistance accessing those social determinants of health. They wanted more support for understanding their infant or child's development, and they wanted to learn how to support their infant and child's mood and behavior. Actually, go ahead and I'll do pre-post at the next slide. So just a few things to highlight from this. I know it is a little daunting, but we did pre and post measures at the beginning of each of our consultations with families. And what we saw was really a big shift after meeting with us. And that meeting could be anywhere from 30 minutes to a couple of hours. But there was an increase in how well that parent felt equipped to manage their concern about their child's mood, about need for resources and how to access those resources, as well as their own mood and what to do with that. And then our post-survey results really was just talking to families about, hey, was this helpful? And if so, what pieces were most helpful? And we saw that on a scale of 1 to 6, not at all helpful, to I got all the help I needed. We really scored high on being helpful, families being satisfied, and feeling like they were heard. And when we asked them, okay, what pieces of those were most helpful? Really the things that stand out were just talking about it and feeling supported, which I think surprised us a little because we kind of thought, oh, getting answers to questions or getting resources. But this, I think, really shows that consultative model of families needed connection in the moment. And when they received that, that was beneficial.
Thank you both very much. We have a handful of questions to sort of tease out some of the other experiences or things you want to highlight that maybe didn't come up in slides that the audience would benefit from. So I'm going to ask a couple of panel questions. They're also displayed on the screen for folks' benefit and to help prompt our speakers. So the first question is really, any new or ongoing initiative will experience barriers. Can you please provide 1 to 2 examples of key barriers that you experienced in lifting these innovative programs and how you address them?
Do you want to go, Ashley, or do you want me to go?
Go ahead.
So I did highlight some of that in our in my slides, but I would say that a challenge for us would definitely be turnover among home visitors, because like I highlighted, the relationship is so important. So these groups get started with the mental health consultants and the home visitors, and you know, it's sometimes I hear from the mental health consultants like, oh, once we're like there and these groups are just great, then somebody leaves and a new home visitor comes in, and then you kind of work at, you know, inviting that person in and building that relationship. So that can be just an ongoing challenge. And I would say probably right now, because we've grown so much, funding, because we are, the mental health consultants bill us at Parent Possible directly. So that's nice. The sites don't need to deal with any of that. But I think because we have expanded so much, being able to pay the mental health consultants is always kind of there in the back of my mind.
I would say very similarly. I think funding is also always kind of at the forefront of our mind as a preventive service. That can be really challenging. So even though all of our providers are licensed in Colorado, they're providing some health and behavior services, we have not found a successful way to offset those costs through the regional accessibility entities or you know, Medicaid access. We do have a current sustainability plan that helps our program stay operational. It does not help us expand. And so that is a challenge in thinking about, you know, we have this service that we feel is really beneficial, that has some good response. We would love to share it at a wider audience, and that is challenging to do with our current funding. And then I think similarly, there's a lot of turnover, and having buy-in for the program at all levels is challenging, because WIC is a federally funded program that then goes down to you know, state entities, and then from state entities it goes down to regional entities, and then regional entities. So they're at every level. There needs to be buy-in, and some people really get it, especially the ones that we're working directly with. But some of those upper levels have a hard time understanding how we're supporting WIC staff and WIC families.
And can you share a little bit about how you've intentionally embedded equity in your workforce development or in your service provision?
For us, we have the PAT, Parents as Teachers, and HIPPY programs have embedded this already into their programs. So our models as a whole do this by the home visitors are from the community. So they're representing the demographic of the families that they're working with. We also have trainings. We use interpretive services when we do trainings. And we have Spanish speaking mental health consultants and trainers. And we also allow the sites to choose their own mental health consultant. So it just kind of depends. Sometimes they say, oh, we know somebody and we really want to use this person. So then I will meet with that person. And that's a fantastic situation because it's already built in. That relationship a lot of times is already there. But there are also sites that are like, we don't know a mental health consultant, so I will work with the site and the mental health consultant. And ultimately, it is the site's choice if this is the mental health consultant that they want to work with.
And as I mentioned a little bit earlier, we try and embed this throughout. We really do find ourselves grounded in the diversity-informed tenets. Also, I think WIC is getting better at really recognizing what Christina's saying as far as it's really important that the individuals providing the service are matching the demographics of the communities that they're embedded in. And so, you know, we are really supporting that, and we are doing our best to kind of model that as well. It is challenging because of some challenges, I think, systemic racism and access to higher education has been challenged. And so we find that it can be sometimes really hard to hire a diverse workforce, but that's an opportunity that we're always looking for, especially through our postdoctoral services. And I would say another way that we build equity in is really Warm Connections was born out of the desire to make these services accessible to all families, regardless of socioeconomic status, regardless of their, you know, race, background, ethnicity, and really working to kind of be in the community where they are.
And now that your programs are established, what do you see as the biggest opportunity available in today's landscape?
I definitely think we have an opportunity to expand this to more PAT and HIPPY programs, even outside of Colorado. Maybe to help people figure out, or, you know, other organizations sort of figure out how they could bring this kind of work to, you know, what they're doing, because we've put in the time and the effort. And then also, I currently am already seeing it's an opportunity, certainly for some bilingual mental health consultants, you know, to be a part of, you know, we're continually asking for bilingual mental health consultants. So maybe an opportunity for more people to be able to do that.
I really thought hard about this question. I had some pretty immediate answers, but then I stopped and kind of thought and thought about how we really came to the conclusion about WIC. And I think part of that is, you know, the needs need to come from those specific communities. They need to have a voice in saying, we want this, we value this. And I think they need to have the input. So I think it's in communities who are expressing a need, and really partnering with those communities to provide a service where, you know, they feel they can access, where they don't feel stigmatized, where they feel supported. Yeah.
All right. Last question from our panel. I think we're all interested in hearing what's next for you in your program. So thinking in the very short term or near term, what do you have planned next for your individual program?
Well, for Parent Possible, we would like to grow our HIPPY and PAT programs in underserved communities in Colorado. So that would mean also growing EHV because we want everybody to have access to that. And then possibly looking at maybe a broader evaluation for EHV because we've added so many sites and it's in such a short time. So sort of expanding what our evaluation looks like.
As I mentioned a little bit earlier, until last month, for the past 3 years, the service delivery of WIC in Colorado was kind of flipped on its head. And only now are the clinics kind of getting back up and deciding what this new kind of hybrid model will look like. So I think what that means for us is really reevaluating the staff and the family's needs. So as they come back and start to utilize these services, really hearing from them, what's helpful, what do you want, and how can we support you? And so really some significant kind of program development and program evaluation is on the horizon for us in the near term.
Wonderful. Thank you both. Sarah, do we have a couple minutes to potentially take questions from the audience, or should
we have 2 minutes left, and we actually do have a question that just came in through the chat. If it's okay for me to read that to you. So how are parents and mental health consultants connected in the WIC clinics? For example, is a mental health consultant on site and the WIC staff walks a parent kind of down the hall, or is there some other mechanism of connection?
Great question. So when all services were delivered in clinic and as we go back into in-person services, there is a mental health consultant staffed at each clinic, and it is that kind of parent identifies or shares a need with a consultant or an educator, and they're connected immediately. We also have a referral system. So if we're not in clinic that day or it's a remote visit, we have a way that they can ask for permission, get a signed release, and then provide us their contact information so we can follow up.
Thank you. That was the only question that came in through the chat. We have just a minute left. If there's a last question that anybody wants to throw in here, please feel free to do that now.
Thank you all for letting us share with you. We're super excited about the steps that we're taking to expand access and equity in Colorado, and appreciate your time and attention while we walk through some of those programs. I wanted to leave a little bit as we are in this conference as far as, how do you meet Colorado families and children, early childhood professionals where they are? And I think these programs are great examples of that. Be courageous, start small. Good ideas are worth testing. Build those partnerships. We can't do this work alone. Engage others and complement each other's expertise. Ask, listen, and respond. Our communities know what they need. And then share the lessons learned, which is what we're doing here today. We are wiser together. So I hope you all enjoy the rest of your conference, and we appreciate your time. You can contact any of us for additional information. Thank you.
Thank you all so much, and thank you to our participants for being here. As you probably heard, we will have slides available after on CVent immediately following the sessions. So thank you all so much for being here, and have a wonderful rest of your conference day.